Hi, good afternoon, everyone. Okay, we're recording. People are coming in. Okay, hi, good afternoon. Welcome to October's PrEP webinar. My name is Jen Sperduto, and I'm joined by my colleague, Dr. Emilie Banz, who is also our presenter today. So this is very exciting. And the title of our presentation today is From Hospital to Home, Understanding Housing First and Supportive Housing for Behavioral Health Recovery. This presentation is sponsored by the department, sorry, of New Jersey Department of Health and the New Jersey Department of Human Services and the Rutgers Institute for Inpatient Psychiatric Rehabilitation. And Emilie and I are both from the Department of Psychiatric Rehabilitation and Counseling Professions at Rutgers University. So today's training is an interactive training, and we encourage you to ask questions throughout the presentation. And there's a training evaluation that will be available at the end of the presentation that will include handouts, training materials. There's a few live links that Emilie's going to show today that are available for access in the training evaluation. And a recording of today's presentation will be available on the Rutgers website, the Rutgers IPR website tomorrow. And I'm just throwing that up in the chat box so you can see it. And again, you don't have any microphone, so if you have a question, you can type it in the chat box. Next slide, please. So the disclaimer today, the Psychiatric Rehabilitation Educational Program, or PrEP, is an online forum for a variety of topics relevant to inpatient psychiatric hospital staff. And while Rutgers and DBHS, DMHAS are co-sponsors of the program, the PrEP webinars are peer presented, and as such, content is independently developed by the presenter each month. The views and opinions expressed in the program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. Next slide, please. We are recording, just to be mindful of that. That way we can provide you with a recording of the webinar on our website tomorrow, and they will be archived. Next, please. All right, I'm going to turn it over to Emilie. She's going to introduce herself, and I'm going to be manning the chat. So if you have any questions or want to pop in and say hi, I'll be over there. Thank you, Emilie. I'm going to turn it over to you.
Thanks, Jen. So good afternoon, everybody. I just wanted to briefly tell you all a little bit about myself. As Jen noted, I am a lecturer in the Department of Psychiatric Rehabilitation and Counseling Professions here at Rutgers School of Health Professions. My role is to provide training and technical assistance to community mental health agencies, specifically supportive housing agencies, which makes this topic very important to me specifically. I also have a background as a direct care staff member and a manager working in supportive housing and community support services programs. And I am a licensed professional counselor, and I continue to provide counseling in a private practice setting. So transitioning to our content, just to kind of introduce and give a little bit of an overview of what I'm going to be talking about today. So as I'm sure many of you know, right, there really is a need for effective recovery-oriented services, especially within the discharge planning process. So it is essential for community providers as well as for inpatient psychiatric hospital providers to understand the different housing solutions that are out there for folks. So in this session, I'm going to explore the housing first and supportive housing models, which are two evidence-based approaches that really focus on stable housing as a foundational step in recovery for individuals with serious mental health conditions. I'm going to talk a little bit about the core principles, look at outcomes, and then discuss the vital role that hospital staff play in connecting individuals who are in the hospital to housing resources in the community. So the goal today is really to equip you all who are on inpatient teams with the tools you need to support patient recovery beyond the hospital walls. Just to highlight our learning objectives for today, by the end of this session, I'm really aiming for you all to be able to define the housing first and supportive housing models, understand the key principles that guide them, and recognize how they support people with serious mental health conditions. I'm also hoping that you all will learn how your team can help connect patients to different supportive housing programs in the community in order to hopefully reduce their risk of cycling through between being unhoused and going back to the hospital. So, to understand why evidence-based housing models like housing first and permanent supportive housing are necessary, it's really important to first explore the broader context of homelessness. Homelessness is not just a housing issue, as I'm sure many of you know. It's very much a complex public health crisis that is intertwined with factors like poverty, trauma, systemic inequality for folks, as well as gaps in healthcare and social services systems. Individuals who are unhoused often face multiple barriers to them becoming housed, such as their mental health conditions, potential use of substances, any chronic physical health conditions they might have, as well as lack of income or identification, which can make it difficult for them to access stable housing without needed support. In recent years, we've seen individuals who are unhoused in the community rise in many parts of our country, particularly among individuals who have serious mental health conditions or co-occurring disorder. So I think this really highlights the urgency of approaches that don't just focus on the symptomology of individuals, but really address the root causes of their experiences with being unhoused and potentially offer long-term stable housing. So, in terms of the impact of homelessness on service users, um, the impact is really profound and multifaceted. So research does show that individuals who are unhoused are significantly more likely to suffer from both physical and mental health conditions. So for example, they face higher mortality rates and are more likely to live with chronic pain, have dental issues, and have health conditions like arthritis, which are often untreated or potentially poorly managed because they're unable to follow up with their healthcare consistently due to access. Mental health conditions are also much more common. The rates of diagnoses of individuals who are managing symptoms of depression, schizophrenia, bipolar disorder, and post-traumatic stress are all elevated in this population. Additionally, individuals who have a co-occurring mental health condition and substance use are also very high in this population because individuals could potentially be using to cope with the trauma and instability that they're facing. Even though this population has significant healthcare needs, they're also less likely to access routine or preventative care due to issues like stigma, logistical barriers, right? It's very hard to access a doctor's office consistently if you are living on a street in one area of a city and then having to move to a different area of the city the next day. As well as a lack of insurance or identification, right? When people are unhoused, they often are unable to keep track of their belongings, theft occurs, and it could potentially be hard to renew insurance because they don't have an address. So the result ends up being that many individuals end up in emergency room settings instead of receiving timely coordinated care that a lot of us are able to receive when we are stably housed. In terms of hospitalizations, one of the consequences of untreated health conditions for unhoused folks is the increased use of emergency services as well as inpatient services. So individuals that do not have stable housing are more likely to be hospitalized, not just for physical issues, but also for psychiatric reasons as well. Many individuals rely on the emergency department as their primary source of care, which leads to frequent visits, which can then lead to higher healthcare costs. They're also more likely to arrive by ambulance, and once at the hospital, they often face difficulties during discharge planning because they have no safe home return to. And because they don't have stable housing, individuals might be kept in the hospital longer than what is medically necessary or discharged to a shelter or the street, which could potentially further exacerbate their health problems. Additionally, individuals who are unhoused are less likely to have insurance and more likely to be transferred to a psychiatric facility rather than a community-based setting, which then can create a cycle of institutionalization for the individuals, but incorporating programs that are rooted in housing first or supportive housing can often break this cycle. So let's transition to our housing models, right? So in taking this larger context of homelessness and how it impacts individuals who are unhoused, right? Thinking about those elevated health risks, the over-reliance on emergency services, and the challenges of discharging someone without stable housing, right? Let's focus a little bit more on these solutions. So there are evidence-based housing models that have been developed to specifically address these issues, with a focus on providing stable housing as a platform for recovery and wellness. I'm going to specifically talk about housing first and permanent supportive housing. And these models are not just about giving someone a roof over their head. They're really focused on recovery, right? And this idea of recovery in the sense of restoring dignity, reducing reliance on high cost services, improving outcomes, and really supporting long-term recovery. Before I get into housing first, I do just want to kind of put that disclaimer out there that I know that there is some challenges currently with terminology related to housing first or permanent supportive housing models. I know that SAMHSA has changed their housing guidelines and philosophy related to those models. So what I'm really going to be focusing on is just the evidence, because there is a good deal of evidence to support these models. And a lot of what you might come to find is that even though some programs might not define themselves as using housing first principles or using permanent supportive housing principles, the philosophy of of those programs do follow those housing first and permanent supportive housing philosophies. So just putting that disclaimer out there. So what is housing first? So housing first is both a philosophy and a practice that really looks to reimagine the way we approach working with unhoused individuals. At its core, housing first provides people with immediate access to permanent housing, no strings attached, which means that housing first providers do not require someone to be sober. They don't have to be involved with services or treatment services. They don't have to show that they're ready to be housed. They are just housed because housing is a basic human right. This model also flips the traditional approach on its head. Because we are not requiring individuals to be stable in their mental health condition or be completely sober before qualifying for housing. It places people into permanent supportive housing immediately without any of those preconditions. And once housed, individuals can then engage in voluntary services at their own pace. This model is also person-centered, emphasizing choice, dignity, and trust. So housing services are there. Individuals just have the choice related to whether or not they want to choose and engage in services. There are 4 principles of supportive housing. The first is immediate access to housing and consumer choice. So again, no preconditions for entry. An individual can make their own decisions about participation in services. There is a separation of housing and services. So housing is not contingent on compliance with services. Losing housing is not used as a consequence for non-engagement. And this separation of housing and services is also something that can be very helpful for folks. When I was working in the community in supportive housing settings, having a separate landlord to kind of engage with the individual related to rent, related to the state of their apartment, related to abiding by their lease, was something that helped me as a service provider to continuously build that rapport with the individual and ensure that our therapeutic relationship remained stable so that I could focus on supporting them with keeping their housing. Housing First is also guided by recovery-oriented services. So the services are designed to support individuals using their strengths, focusing on helping them to achieve recovery goals and helping them to really focus on their own personal growth rather than focusing on deficits or symptoms or ensuring that they're quote unquote compliant with services. And the final principle is community integration. When individuals are housed in regular community settings, they are supported in developing natural social roles and relationships, just like any other person in the community. And a lot of the individuals that I worked with in supportive housing lived in regular old apartment buildings where they were able to make friends and get to know other individuals of different backgrounds and really get to be fully integrated in the community. Now, there are some common myths and misconceptions or misunderstandings related to Housing First. The first one is that there are no rules, and that is not really true. Individuals in a Housing First program do have to have a lease, right? As any other person in an apartment building has a lease, individuals in Housing First programs do as well, which means that they have to abide by that lease and follow any rules related to that lease. They also have the same laws and responsibilities of any other tenant. The other myth is that people won't engage in services unless they're forced. But the truth is, when individuals are housed and feel safe, they're more likely to engage in voluntary services. I had plenty of individuals who I worked with who maybe initially felt like, no, I don't want services anymore. But through building that trust and that rapport and that engagement with them, eventually they warmed up to services. Sometimes off the bat, people really wanted services. They wanted to be seen every day, or they wanted to be seen a couple times a week. But even those folks that maybe were a little hesitant because of past experiences were eventually very happy to receive services and support from us. There's also this myth that Housing First only works for low-need individuals, but evidence does show that Housing First is highly effective, even for those with complex or high acuity needs, often with better outcomes than more restrictive models. And when thinking about individuals with higher needs, right, certain programs like a RISK team, which is a residential intensive support team, or a PAC team, which is specific to New Jersey, which is Program for Assertive Community Treatment, or an ACT team, an assertive community treatment program, right? They provide services to really higher need individuals. They're seen more often, and that supports individuals to have good outcomes because they're getting the support that they need. They're learning skills. They're learning the information needed to remain stable in their apartment. They're having access to resources, and that's what's supporting these good outcomes for them living in the community. So Housing First kind of paved the way for these types of programs. Permanent supportive housing is almost like a sister, kind of niece or nephew kind of program to Housing First. There are definitely some overlap and some similarities with permanent supportive housing and Housing First, but there's also some differences which you'll be able to tell. So supportive housing is a long-term solution that pairs permanent housing with flexible, individualized support services. It's targeted towards people who face the most significant challenges. And that is really talking about individuals with serious mental health conditions, substance use disorders, and long-term homelessness. So a lot of the times you will see that permanent supportive housing programs are specifically for individuals in these populations. The key difference, though, is the housing is permanent, right? So the idea is that individuals in a permanent supportive housing program will be able to stay in that housing for as long as they need. It's not transitional or time limited. And similar to Housing First, services are available, but they're not mandatory. So permanent supportive housing does have some key elements. The first key element is that tenants do have a lease in their own name. So they are renters first and foremost. They're renting their apartment, and they're first and foremost that tenant, not a program participant. Again, participation in services is not required to keep housing. People can use services when necessary. And again, a lot of these programs will offer various kind of levels of services, right? So you might have individuals that want to be seen 7 days a week, and programs will provide services to them 7 days a week. You might also have individuals who only want to be seen once a week. But the hope and the long-term goal, essentially, at least from the provider's perspective, is that eventually individuals will get to a point where they're only being seen twice a month or once a month or maybe every 3 months, so that essentially they can completely titrate off services. The other important aspect of this is that services can also be reinstated if needed by the individual. And I had that happen when I was working in the community. Sometimes we had somebody who we were working with who was doing really well and didn't want services anymore, and we discharged them. And then something happened in their life, right? Like something happens in everybody's lives. They had a death in the family. They had a life event like losing a job or losing a really important relationship, and they wanted services again. And we were able to readmit them into our program and start providing services again. In permanent supportive housing, individual choice is emphasized, right? So the recovery goals are really rooted in the hopes, dreams, and aspirations of the individual. Rent is affordable, typically no more than 30% of income. Some programs, it might be 40% of their income as opposed to that 30%. Housing is integrated in the community, so individuals live among people who do not necessarily have a disability. I worked with individuals who lived in housing owned by the organization that was funded through HUD. So those folks did live with other individuals with disabilities. At the same time, though, I worked with individuals who lived in a regular old apartment building where maybe there were other people living who had disabilities, but that wasn't something that we knew about. So housing is essentially anywhere in the community. Again, rules and rights are consistent with those of other renters. So like Housing First, they have to follow their lease as well as any applicable laws where they live. If they are receiving services, they might have to sign something called a consumer service agreement, which also outlines certain responsibilities that the consumer might have being a participant of the program as well as living in the unit. And then support services are really tailored and chosen by the client, right? So the individual is able to determine what their recovery goal is based on their hopes, dreams, and aspirations. And then the services that we're providing to them are really linked to those goals. And this ensures that housing is truly stable, empowering, and also non-institutional, because we're really supporting the individual's choice and their autonomy to make their own decisions. Now, as I noted before, Housing First and supportive housing have been shown time and time again to have really good outcomes. There's a lot of evidence, there's a lot of research that has been done on these programs, and the evidence essentially shows that they do work. So they lead to reductions in homelessness, decreased emergency department visits and hospitalizations, longer housing retention for individuals, and improved mental health and quality of life for folks. Additionally, these approaches are cost effective, especially when compared to the high costs of emergency care, hospitalization, and incarceration, which we know can happen when individuals are unhoused. So I wanted to also give a little bit of an overview of what support services in supportive housing settings might look like. So when we're thinking about rehabilitation services, right, we're really focusing on services related to individuals choosing a valued role by helping the individual to explore their goals and assess their readiness. Getting that valued role, like supporting the individual and finding opportunities, whether it be employment, education, volunteering, or social roles. And then keeping those valued roles, which can look like building the skills, confidence, and support network needed to maintain those roles over time. Goals could look like, or services could look like, support workers helping individuals to remain stably housed. So helping them to avoid eviction, helping the person to learn skills to kind of talk with property managers or their landlord to voice their concerns, helping individuals by educating them on their tenant rights and responsibilities. It might also look like mental health support or support with support for the person in helping them navigate co-occurring disorder. So helping the person to learn coping skills to manage their specific symptoms of their mental health condition, linking the person to resources to navigate their co-occurring disorder, like community meetings for AA or NA, supporting the person in learning skills related to managing a crisis when it occurs, or providing some of those crisis intervention services. For some individuals, it's building skills around taking medication. I probably could not count on 5 hands how many individuals I worked with in my career where I worked with them on medication education, whether that be helping to teach them how to fill a pill box, whether that be helping individuals remember to take their medication, whether that be supporting individuals to learn more about their medications and why they're taking them. So that's also a part of the work that is done in supportive housing settings. There could potentially be health and medical related services. So that could be coordinating with medical providers, as well as behavioral health appointments, advocating for the client in those settings, as well as teaching the client or consumer how to advocate for themselves. There might also be support related to employment and education. So it might be linkages to a job coach, linkages to vocational rehabilitation services, providing some supported employment or supported education services, and then helping the person with daily living skills, right? So there's a lot that goes into living in your own housing setting, right? I'm sure many of you know this. So learning the skills needed to cook, clean, the differences between cleaning your kitchen versus cleaning your living room, learning how to navigate a food store, learning how to just navigate the community, right? There's also a lot of services around and related to community integration, right? Linking up people with the library, linking people up with different community supports or events, as well as different types of peer supports. So there are a lot of services that can be provided to individuals. And I know, at least in my experience working for a couple of different agencies in New Jersey, as well as providing services to supportive housing workers in New Jersey, there's a lot of services that can be provided that are very, very beneficial for folks. So in considering the impact of housing first and supportive housing, um, housing first and permanent supportive housing lead to fewer, longer hospital stays. Um, there's a less reliance for folks on jails, ERs, and on crisis beds. And then for hospitals, there's better with Olmstead, right? Because providing or referring an individual to a supportive housing program is promoting care in the least restrictive environment. So these models really help people move from maybe being in a place where they are institutionalized or feeling like they're institutionalized to community-based living, where they can focus on recovery and stability. So I did a little bit of research on supportive housing in different states. I wasn't able to get to all 52 states. I wish I was able to get to all 52 states, but even if I was, I don't think they all would have fit on this slide because I do know that we often have folks from different states on our call today. But supportive housing actually sounds different depending on what state you're in. So in New Jersey, we have community support services. So if you are at a New Jersey State Psychiatric Hospital and you're interested in referring someone that you're working with to a supportive housing setting, you're wanting to provide them, you want to refer them to community support services here in New Jersey. There is foundational community supports in Washington. There's intensive community support services in Mississippi. There's community rehabilitation and treatment programs in Vermont. There's community mental health centers in Rhode Island. But a lot of states do focus on permanent supportive housing programs. So that language is also something that is still being used in some states, whether that be in Arizona, in California, in Colorado, in Illinois, in New York, or in Nebraska or Ohio. So I would encourage all of you out there, if you are not from New Jersey and from a different state, to take a look at what supportive housing looks like in your state. Something I also want to mention here is that a lot of permanent supportive housing programs across the country either have services that they can, or their program is funded through Medicaid, either through a state plan amendment with Medicaid or through something called an 1115 waiver. So for New Jersey, our community support services, our supportive housing services are funded through a state plan amendment. But for example, Washington State, their services are funded through this 1115 waiver. And I just point that out because your state might not have services right now that are in alignment with supportive housing services, but you might have services that come to your state in the future because a lot of states are taking advantage of these 1115 waivers that are going to allow them to provide recovery-oriented services for individuals with serious mental health conditions and get paid by Medicaid to do so. So now that I gave an overview of what homelessness looks like in our country and how that has kind of funneled into the development of these housing programs, I want to get to all of you who are here, who are on the front line working with individuals in the hospital. And before I do that, I meant to do this poll earlier and I completely forgot and got right into the content, but that's okay. I'm going to launch a poll. And I want to just gauge from all of you who you are, more specifically, what your role is at your organization. So if we have any community providers here, I did put, if you have any CSS providers here, I'll say that you can note you're a community provider. But we have social worker, we have psychologist, we have psychiatrist, we have medical doctor, we have nurse, we have dual recovery specialists, hospital direct care staff, as well as community providers. Oh, thank you, Melissa. I'm sorry, I didn't even think of occupational therapists, so that is my fault. And I'm going to make a note because if I ever do this again, I'm going to add occupational therapist.
Well, 3 OTs in a row.
I know.
Wasn't there?
Sorry, guys. We value occupational therapists, especially in our department. Our department has an occupational therapy assistant program. So we value occupational therapists. So I apologize for that. Yeah, we have another OT here. April, you're a rehab counselor. We also love rehab counselors here. So Jean, substance use professional. I have the dual recovery specialist. So that kind of funnels into substance use. You too, Angela, you could definitely use dual recovery. Wow, we have an art therapist here. That's super interesting. I'd love to hear that. Victoria, you're from the quality management side, so that's really interesting. Karen, you're a manager. Lisa, you're a program administrator. I didn't even know anybody on like the back end would even be coming to this type of presentation. So thank you for being here, and I apologize for leaving you out. Allison, thank you for letting us know you're also an OT. Clinical Services Director, thank you, Amy. So we also have some administrators. Very cool. So I'm just going to give it like another 30 seconds and see if we get any more participants. We have about 60% of people who responded. And I do love to get to 100%, but I also know that's not always attainable. So I will.
I think the other 40% are OTs.
Probably. I will never forgive myself for leaving out all of you very valued occupational therapists. All right, so I got one more response. I'm going to end the poll and I'm going to share the results because we do have some variability here. We have a majority of social workers with us, but we definitely have some psychologists, we have a psychiatrist, we have some nurses, we have some dual recovery specialists, we have some direct care staff, and then we also have community providers, as well as some administrative folks and a few occupational therapists, as well as one art therapist, which I will think that's really, really cool. So I asked this question, and I'm going to stop sharing the results, but I think I'm going to keep this poll up somewhere so I can refer back to it. Because what I really also want to emphasize and what I'm going to talk about is how all of you in the whether it be in a staff working in the inpatient hospital or some of our community providers that have joined us, how all of you support discharge planning and supporting individuals as they transition from the hospital into the community setting. So I'm gonna turn my attention to inpatient staff who do play a very critical role in this process. We know that hospital and psychiatric facilities are the first point of contact for individuals who are unhoused and who have serious mental health conditions. So you all, being the first point of contact, are really the first people to assess, gather information, which can significantly shape the trajectory of a person, as well as support them and lead them toward recovery and stability.
Emilie, before you move on, I just want to remind everybody that we don't have microphones available to talk, so I see some hands raised. Feel free to drop your question in the chat, and I'm happy to relay your question to Dr. Banz.
Thank you. All right. So why you matter? So why does your role matter so much, right? So as I noted, hospital staff are really the first to identify any housing barriers that an individual might be experiencing, as well as begin the process of connecting people to some of those long-term supports. So you all have the unique opportunity to prevent an individual being discharged into an unstable living situation. You can really ensure that continuity of care, right? Starting in the hospital, helping the person to become stable, helping the person to get linked with a community provider so that once they are linked and transition into the community, that care is continued, as well as bridge the gap between clinical treatment and community living. So by taking housing needs seriously and really being mindful of them, you can support individuals in really rebuilding their lives. Your role is crucial and it is critical. So in terms of what effective discharge planning for housing success and what it looks like, and let me know in the chat also if what else you're doing, right, to successfully support individuals in the discharge planning process. I would love to hear from all of you what some of your personal practices are. But I really identified these three key steps. So the first is early identification, right? So really asking off the bat initially about housing status at intake and really identifying and putting your Sherlock Holmes cap on and looking for clues to really determine whether or not the person might have a history of homelessness, whether there's a lot of ER visits or hospital visits, and whether or not they're coming in with income or NID, because that could potentially be a red flag that maybe the person is unhoused or has a history of being unhoused. You also want to collaborate and collaborate early. So you want to bring in those community-based providers, whether that be a housing navigator, maybe you have connections or relationships with certain community providers because you receive referrals from them. Try to do that early on in the process. And obviously don't wait until discharge day or wait until it's farther into that discharge process. And then again, you want to document, right? And this isn't documentation for you. You want documentation for the client, right? So you want to help them collect all of their important documents. A lot of the times the individuals I worked with, they didn't have their social security card. They didn't have their birth certificate. So you need those to get an ID, right? So helping them to secure their ID, helping to link them up with social security benefits, potentially starting the application process with them, getting a verification of disability, and really helping the person gather whatever documentation that you can, so that they will have all of this for once they're actually discharged. And then, yep, Jen.
We did have a couple comments come in on the chat, but it wasn't to everyone. So I wanted to just make sure we were able to read them.
Yeah.
Melissa said that she meets with social workers prior to discharge to coordinate discharge, assure household items are ordered and unit is ready for move-in. And Melissa said that OTs look at all of the skills that an individual might or will need for the community living at whatever level they're at. We work on things ranging from self-advocacy skills, household management, financial skills, symptom management, emotional regulation, meal prep, time management, decision making, problem solving, and the list goes on and on.
Yeah, yeah. And it is so two things. So first, to Melissa, our occupational therapist, yes. And I think the thing that I think stands out the most to me about that, and why I think it's so valuable to have an occupational therapist on the discharge planning team in the hospitals, because you all really are the best person to assess those skills and really assess the types of additional support somebody might need, accessibility needs, and really almost create like, I don't want to say a plan, but being able to then communicate that to the service provider, right? Like I never worked with, when I worked in the community and we received individuals for our program, when we were referred individuals from the state psychiatric hospital, I was never in contact with an occupational therapist, but just thinking back on what I could have known about the person prior to discharge on their ability to self-advocate, perform certain skills in the household, like cooking or cleaning, what their financial skills were like. That having that information would have been so valuable to me personally, because it would have given me a really good idea of where the person's at, potential goals that they might want to work on, and where we could really tailor our support to the person once they came out of the hospital. So I think that's awesome, Melissa. Thank you for sharing that. And then Melissa Fleming, that is the typical process. I know that's the process that we follow, or have followed in the past in New Jersey, right? Meeting with the social worker prior to discharge. And then as the community provider, it really is our responsibility to make sure that they have all their shopping done, pillows, sheets, furniture, cooking items, plates, cups, all of those things are there and present so that when the person is discharged, they can just move right into their unit. So thank you for sharing that as well, Melissa. So getting into this next slide, and although it's not on the slide, I am going to highlight where some of you who weren't necessarily on our poll could fit in, right, to your role in the discharge planning process, right? So in terms of early housing assessment, I have the social worker, I have the nurse, but I definitely think occupational therapists could potentially fall in there. In terms of family and child planning, right? So if the individual is admitted into the hospital and they do have a child, it could potentially be the social worker, the psychologist, the ABA, the community provider, the psychologist, and the OT, really focusing on how to support the person to be able to either regain custody or have a living environment that's going to support their custody of their child. Submitting the referral packet is usually done by the social worker. Housing coordination is usually done by the social worker, the community provider, or potentially hospital direct care staff who might help with, getting an ID or getting other necessary documentation. Same thing with the housing eligibility documentation. That might be more in alignment with the social worker, the psychiatrist, or the community provider. The service referrals, this is where occupational therapists, art therapists, as well as social workers, psychologists, psychiatrists, medical doctor, nurse, dual recovery specialist, hospital direct care staff, right? All of you are face-to-face and one-on-one with the individuals that you're working with, right? So you all know what types of referrals and what types of services they're going to need once they are discharged into the community. And this is where that collaboration between all of these different workers really comes into play, especially for those workers who are working in the hospital setting. Not to downplay the role of the community provider, but when the individual is in the hospital, you all in the hospital are time with them. I might be seeing them as a community provider maybe once a month or every other week, or maybe once a week if time allows it. But you all are really spending the most time with them. So you all have a really, really clear picture of the person's strengths, of their areas of need, and what types of services are really going to be helpful and supportive for them once they are discharged into the community. In terms of helping the person to get an ID or get linked up with Social Security, that's probably more the social worker and the hospital direct care staff. In terms of documentation support, that's really the whole team, right? When you're meeting with somebody and you're documenting the progress that the person is making, that is absolutely very helpful for folks. In terms of the warm handoff, that's typically between the social worker, the consumer, and the community provider. But this joint discharge meeting is really where everybody is coming together, right? The social worker, the psychologist, the psychiatrist, the medical doctor, the nurse, the dual recovery specialist, the hospital direct care staff, the art therapist, the occupational therapist, the community provider, and most importantly, the client, right? To really look at what the plan is after discharge, right? What does the client want to focus on as they transition into the community? What areas of need can the community worker provide or hone their services on or to? And Melissa, just acknowledging your comment, you said it is critical to discuss needs of consumer with consumer and OT staff to get actual progress. Asking pertinent information is critical. With some hospitals, it is difficult to get time with them, which is understood. Yeah, and this is where I think, setting up, taking time to have some of these, either whether it be a virtual meeting, if that's possible, or a phone call or an email, and really being in constant communication with each other, I think is something that can be really important. And also identifying who you are, and identifying the names of the folks who were meeting with people. Because I know for me, when I was working in the community, I often knew the social worker, and that was the person I was mainly in communication with, but it can also be helpful for the community provider to also be introduced to some of the other staff that are working with the individual, though also recognizing that a lot of hospital staff are very much overburdened. I know a lot of hospitals are understaffed, which makes your job 1,000 times easier. So just recognizing that as well. So I think we have a little bit of time for this activity. So I just want to do a quick activity where we can kind of work with Maria a little bit, because I would love to hear how all of you might work with Maria. So we're going to think about Maria, who's a 36-year-old woman who's currently hospitalized following an episode of mania, which presented with some psychotic features. She has a diagnosis of bipolar 1 disorder and PTSD, along with a history of untreated hypertension and occasional ambivalence with taking her psychiatric medications. Although Maria has a past history of cannabis use, she reports stopping use prior to her hospitalization. Prior to admission, she was unhoused and living on the street and in shelters when able. She currently has no income and is not connected to public benefits as her previous SSI was discontinued after a missed recertification. She lacks basic identification documents, including a government-issued ID and her social security card, and she has no access to a phone or transportation. Despite these challenges, Maria has expressed motivation for change, stating, "I'm doing better now. I don't want to go back to a shelter. I want to get stable. I just need help finding a place that doesn't treat me like a problem." So thinking of your role, your specific role at your hospital, if Maria was somebody who was a patient and you were going to refer her to a supportive housing program, as part of the discharge planning team, what would you do to support a successful discharge for her? Let us know in the chat. What kind of steps would you take? And as you all are thinking, just kind of throwing out some questions that you might ask Maria, or you might kind of ask yourself as you're developing this discharge planning process, right? So what we know off the bat that Maria is unhoused, right? But we might be looking for some of those red flags related to housing instability, and maybe trying to find more information about some of Maria's past housing experiences and maybe what led to her current experience of being unhoused. We might think about who we want to contact for a referral. We might think about, again, that documentation. So Melissa noted in the chat that a photo ID is essential, right? People often need an ID to be housed. So really thinking about helping her to get that ID, right? And absolutely, Carissa, gathering those documents to get that identification. And also seeing what she needs to get her SSI reinstated and what that process looks like. And then also thinking about what community resources and referrals that Maria might need, right? What was it like for her when she lived independently in the past? You know, was she able to cook? Was she able to clean? Are there any assessments that you can do in the hospital to assess her skill level? Maybe referring her to that occupational therapist. Really trying to assess what type of housing might be beneficial for her, whether that be maybe being on her own in an apartment or maybe living potentially with a roommate. Just thinking about some other concrete things, right? So we might screen for housing instability, right? We're going to get all of those documents together in order to get her ID, get her social security card, get her birth certificate. We might ask and reach out to some community housing providers, ask about waitlist times, ask about eligibility, ask what specific documentation they need. We might also get that referral packet together, right? What type of referral information is needed for the supportive housing provider, and working with them to set up a time to come in and meet Maria. And yeah, I'm getting some really good stuff in the chat, right? So assessing her abilities to live on her own, getting her to get all the information. So just for time's sake, I do want to move on to the next slide, but I'm almost done, I promise. But yeah, to Carolyn's point, right, encourage long-term recovery efforts for mental health symptoms and substance use, consult social worker regarding access to identification, address any barriers to maintaining independent living. Absolutely. Right. So, in thinking of some best practices, right, we want to make housing part of the treatment plan from the beginning. You really want to hold those interdisciplinary discharge meetings with those community based providers, getting those meetings scheduled early on and really making that connection with the community provider. I know as a former community provider, I would love that. Um, Identifying and addressing any legal or income barriers, again, very much early on, assessing for whether or not they have their social security and an ID from the beginning, and immediately working on getting those things for the person. And then educating clients about their housing rights as well as their tenancy rights. And when we're working on looking at this, right, we're really looking at a cultural shift, right? So, really thinking about how you in the hospital as a hospital worker can kind of shift the culture of to more of recovery, trust, and collaboration, right? So really focusing on those strengths. As someone just said in the chat, Angela, right? Really identifying those strengths and really focusing on and believing in a person's ability to live in the community, trusting clients to make their own choices, even if they make some mistakes, and really embracing that interagency collaboration, right? Because at the end of the day, those community providers, they want to work with you. They want to work with you. They want to make that transition into the community seamless, and really involving them from the beginning can be super helpful. And then just some really quick key takeaways, right? So housing first means immediate, no preconditioning housing. Support housing is that permanent housing plus voluntary services. Um, Inpatient teams play a crucial role in successful transitions. And these models, these housing models support recovery, reduce hospitalization, and improve client outcomes. So I'm sorry that we didn't have time for a full-on discussion, but if anybody does have any questions, feel free to put those in the chat. I do just want to share a couple of resources that we will have available for you. You'll get an email tomorrow with these resources. So we have the Permanent Supporting Housing Evidence-Based Practices Toolkit. The National Alliance to End Homelessness has some information related to ending homelessness and what Housing First is. And then there's also a YouTube video on the introduction to supportive housing from the National Academy for State Health Policy, which has a lot of really good information just on what supportive housing is if you're interested in learning more about supportive housing. Jen also put the IPR website in the chat as well as the training evaluation. And really quickly, I just do want to remind everybody that we do have our IPR award nominations open. So we are continuing to accept nominations for the second annual IPR award. This award honors innovative patient psychiatric rehabilitation programs that embody psychiatric rehabilitation goals, values, and principles. The IPR award committee will review submissions and select 3 finalists. Finalists will be featured on our website, and you all, as IPR members, will vote to choose the winner. All nominees will receive a certificate of appreciation, and the winner will be awarded a plaque recognizing excellence in inpatient psych rehab. So the link will be provided tomorrow in the email as well. If you want to scan the QR code, you can also scan this QR code.
I just put the
So,
link in the chat too for the
oh,
IPR award nomination, just so you have both.
thank you, Jen. And the IPR award nomination link is also in the chat. So that is all I have. Thank you all so much for attending. I hope that this information was relevant and helpful for all of you, in hopefully fostering and kind of collaborating with community providers through this discharge planning process. And Melissa, I'm sorry, we don't have the ability to unmute people. So if you have a question, you can definitely just put it in the chat.
I know Melissa had some information about Social Security that she wanted to share, but I asked her to put it in the type it in the chat.
Yeah.
Melissa, if you would like to email me directly with that information, I'd be happy to send it out to the group tomorrow. Everyone who attended will get an email from us in the morning as a follow-up with the links and any additional information. So if you'd like to share that and I could pass that along, I'd be happy to do that for you. And so we posted the link to the training evaluation. You can get the slides, the handouts, and the live links, and the link to the website, and the link to the IPPER award. And all of that can also be found on our website that I also linked, and you'll get an email from us tomorrow. So thank you all for joining us today, and our next prep will be on November 18th. So we will see you then. Take care, everybody. Have a good month, and we'll see you next time.
Take care, everybody. Thank
Bye.
you.